My name is Ellesse-Roselee Akré. My pronouns are she, her, and I'm an assistant professor in the Department of Health Policy and Management in the Bloomberg School of Public Health. For me, I love to spend time with my wife and our two dogs, Leonidas and Theodore, aka Leo and Teddy. I love to cook. Cooking is the kitchen is my canvas. I can't sing, I can't draw, I can dance a little bit, but I can't really dance, so I can't just like go to a dance class and just sweat it all out. But I can cook. I love to dice. I love to saute. The more elaborate the meal, the better. And then I also golf. I found like golf has been a very surprising, wonderful outlet. And I realized the reason I love it is because there's nothing else you can think about while you're golfing. I have yet in my going on 4 years of golf, have I been like, oh, I wonder if I turn on the wash machine. Like as soon as I grab a golf club, there's nothing but golf in front of me and nothing but golf behind me. So I really enjoy it for that. So it's a series of things, right? It's like it may or may not be explicitly about being LGBTQ plus. A lot of it is around this idea of these collective ideas around chosen family, around loving in loving yourself and like walking into your own, and really like tirelessly fighting and constantly combating those that are trying to either gaslight you into thinking that you're not as powerful as you are, or gaslight you into thinking that what you're doing is wrong simply because you're different. Oh, and the other piece is like platonic friendship and how meaningful and powerful that really is. Like I feel like when I think about like all the media that I consume, whether it's around like my blackness, around my queerness, around my general just like love and reliance on community, I feel like they all encompass that. So what comes to mind is like one X-Men. Like for all of his faults, Charles Xavier did an amazing thing about bringing a very diverse group of people together to recognize their own power and strength and to continuously fight back against those who would rather deny you your power and throw you away just because you're different. Or it's like the Gilded One series. I love how it takes a story about just women who were gaslighted into thinking that they were evil, but when they were really the powerful creation of the gods, and only to find out they were gods themselves. Or it's just like even Grey's Anatomy. I was just talking about how I just love the Christina Yang and Meredith Grey, like having your person be a person that wants nothing from you except for to love you and show you how great you are. Like those are the type of things that really resonate with me in when it comes to the media that I consume, and all of those things I think transcend across all of my social identities. So I like to say that I do this work selfishly. As a Black queer woman who is only getting older, not getting any younger, I realize that I'm going to age into a system that doesn't really cater to or consider people who live like me and who look like me and who love like me. So it's kind of I would say arguably selfish way of trying to improve the healthcare system before I completely and absolutely have to rely on it. So growing up, my family didn't have a lot, and we were on Medi-Cal, or what is known nationally as Medicaid. And so having that public health insurance, we always didn't get the best care. But I remember specifically when I was growing up, my oldest sister, she would always have really, really painful menstrual cycles. And every time we went to the doctor, they'd say like, oh, that's normal. And then eventually she got diagnosed with endometriosis. But like, it was just, the pain was just so extreme. And she wasn't really getting heard, and no one really listened to her, and she kept getting pushed off to different doctors. Come to find out, she had a congenital defect where her intestines were wrapping around her kidneys, and that's what was creating the pain. And so it ended up developing a lot of scar tissue to the point where she had to have her kidney removed. And it was like thinking that could have been avoided. Now, she struggles with a lot of like pain and a lot of like consistent chronic issues that could have all been avoided if someone would have listened to her. And it's just like, as I got older, I didn't have the language to really articulate what was happening, but it's just like, just that general being judged, being presumed that we don't care for our own health, that we just were combative, that, that women are complainers, all these things that were just kind of like looped into healthcare and our healthcare experiences. As I got older, realizing that it only gets worse when you have more diverse identities, whether it be a diverse sexual orientation or gender identity or diverse racial background or different abilities. I just always felt like we could be doing better. And as I got into college, I found research and found that there are ways that I can contribute to us kind of maybe doing a little bit better with every change in policy, with every piece of information and evidence that we create in research and science and public health. I started college as a psychology major, and then maybe after my second semester, I added an Africana Studies minor. I had intended to go to college to get my master's in family therapy and become a pastor and counsel. Yeah, I grew up in the church. Growing up, life can be a little interesting. There's a little bit of chaos. Poverty throws a lot of curveballs, and it's like being raised in the church, and in certain areas where it's easy to kind of fall into certain patterns. It was just a safe space. A bunch of things that could have been potentially dangerous were circumvented because I was able to find a group of friends that loved me and a group of adults that took the time to mentor me and become a hedge of protection when the world had other intentions for me. And so as I got older, I wanted to be that for other people. Like I realized very young that a lot of my problems that were out of my control stemmed from just not having resources and not having the tools to be a healthy adult, like not having the tools to address anxiety and depression, not having the tools to address to be able to communicate and to have healthy relationships, not having the tools to recognize when to learn what love is and what love isn't. And you walk around and see a lot of people who are just the walking wounded hurting each other, and I just felt that there was something I can do about that. And so going into undergrad as a psychology major, you're looking at all these theories around behavior, but the individual is the unit of analysis. And so I started having this very individual mindset, like people make choices, people decide what they want to do with their life. And then as I got into research and started learning about social determinants of health and learning more about sociology and learning more about just how choices come into play, just how it's not a matter of having choices. Sometimes people just have options. And if you have nothing but bad options, you're going to end up making a bad choice. And so it's like I started to arguably become less judgmental and critical of people, and started realizing that there are a lot of other social drivers that are contributing to a lot of the negative outcomes that we're seeing. And I found that if I kept trying to address these issues one person at a time, that's a great thing to do, but it wasn't my ministry. And I grew up believing that your misery is your ministry. And I realized that there are global things, larger things that I could address in a macro way by going into public health and addressing policy rather than individual therapy. I think individual therapy is great. I love folks who do therapy. I love my therapist, but I realized that just wasn't my ministry. So I graduated from college during the Great Recession, and so I don't remember where I heard this quote, but it's always stuck with me. During the time of prosperity, education is an ornament. During the times of trouble, education is a safe haven. So after I finished my undergraduate degree in 2009, I went right into graduate school and got a master's in women's health. And then after finishing that in a calendar year, I went back home to California and started working at nonprofit organizations. In Los Angeles was my first organization, Black Women for Wellness, where I worked on these green change projects where we would go around to barbershops and beauty salons and talk to different people about the types of products they were using on Black people's hair and nails and lipstick, and how the combined effects were having impacts on our bodies, impacting cancer and different sicknesses, and just basically collecting data, doing some qualitative research, and learning from people on the street. And then I got another job where I worked at the intersection of health policy and public policy, where we're looking at food zoning, because there are a lot of food deserts in Los Angeles. So really getting to learn about the policy process, the advocacy process, and the lobbying process, and what the differences between the two of those are. Fun fact, it's not just how much you get paid, but for the most part, it was a really great opportunity to get my boots on the ground and learn a lot about what happens with policy, how it gets made, and what happens in real time between the individuals and the interest groups and the lobbyists and the policymakers and the politicians. It was a great, it took everything I learned in books and made them very real. So my research focuses on how structural racism and cis heterosexism impacts individuals' ability to access healthcare, that is respectable, that is safe, and that is affirming to their social identities. So all of my work focuses at the intersection of race and ethnicity, LGBTQ identity, and I've recently added aging. Yeah, no, this has been a really special Pride. I got the opportunity to march in the parade with Johns Hopkins University and Johns Hopkins Medicine, and it was really great. I think just being new to the institution, it's hard to, it's so big, and it's really hard to find your people. And so to just get out there and find folks who are, who are allies, who are queer, who are like really out wanting to support the community, it was really great, and it was inspiring. And I made a pact with a really good friend of mine. He's actually my life twin in a lot of ways. His name is Dr. Philip Graham. He's a counseling psychologist, and we decided that we wanted to build more communities. So we invested in going to like every single event that was available. So we went to drag brunches, we went to happy hours, we went to the parade, we went to the block party, we even went to the after party. And so by Sunday, I was done. But it was really special. I met a lot of wonderful people, and I really can see myself getting enveloped in the Baltimore community. Thinking about like my early in my career, Dr. Patricia Tackett. She just saw some. I was at a school that had 35,000 students with 3% Black, and that included Africans and athletes. And so there wasn't a lot of community. And just like arriving in her classroom and her just saying like, "Have you ever thought about research?" And I'm like, "Well, no." I'm here to get this undergraduate degree and start my life so I can be a whole adult. And she just saw, it's like when I think back, I would want to go shake that little girl, like, slow down, there's nothing out there but bills. So, but she just really encouraged me and gave me a lot of great opportunities and introduced me to research and to different opportunities that helped me kind of find my way throughout undergrad. And then folks that I really believe in, like peer mentors and folks that just like guide you. So one of my sorority sister, Dr. Portia Curry, she just got her PhD from University of Southern California, the real USC, sorry. And she's just always been an inspiration to me. Took me under her wing as a young college student, taught me everything from how to do a real smoky eye makeup to how to cook, and really changed my whole college experience. I don't think I'd be where I am without her. And then other folks like Dr. Gilbert Gonzalez, Tara McKay, Christopher Carpenter at Vanderbilt, where I did my postdoc at the LGBTQ Health Policy Lab. I learned so much for them, and that was the first time my education that I ever felt heard, seen, and understood by my advisors. And their support continues even to this day. So, and they've been absolutely amazing. And then other folks that just inspire me, like Dr. Lisa Boleg, who runs the Intersectionality Training Institute in Philly every summer. Like her encouragement, her support, her inspiration, she's always challenging me to be better, whether it be a personal conversation or stumbling across an article that she wrote about how to just push the work that we do in health equity and intersectionality even further. The list can go on and on. Like honestly, you don't do anything of any value or importance, especially in public health, especially in health equity, without a strong support system and a community of people that you can trust and believe in you. That's a good one. I think on one level, my friends. Like I have friends from different walks of life, different experiences, and recognizing that like if you ever want to if you ever want to come down off your high horse as a PhD, go visit your family. Like they call me doctor in jest, and they're so rude about it. But it's just like part of that is just like connecting with people like that, like I love, who have different experiences, who have parents with different experiences and backgrounds. It's just kind of like a reminder of like why I'm doing all of this. And then like my frolics, my friends who are my colleagues, like just their different experiences and their perspectives, like they keep me grounded. And then also really engaging in the community. Like one of my career coach, Melody Goodman, she's at NYU. I hope NYU says I didn't mess it up. Her lab does monthly community service, and it's just like, so she's like, it's one thing to, because she's a biostatistician, it's one thing to do all this, these numbers and start to forget like, oh, these numbers correspond with people and human experiences and lived experiences and suffering. Like she like takes her whole lab and they do community service every month, so people are reminded why they're doing this. And so like as I as I like start to grow, as like these are things that I want to incorporate. I don't have a lab just yet, but it's just like I want to like I like to stay connected. Like a couple of weeks ago, probably 3 weeks ago, I went to the National LGBTQ Elders Day with Chase Brexton just to like meet people and talk to folks and offer up like tell them, hey, how are the opportunities to volunteer. Like I'm new to the area, but part of the staying close to the ground is remembering the people who knew you before you knew you before you knew you, and then like really connecting to the people that you want to work with, not study. I don't study anyone. I want to work with populations and really being with them, connect with them, talking to them, leveraging your resources to help them. That's a great way to stay connected, and that's what I try to do. And it's not easy because you look up and it's just like, yo, you got to do 15,000 things, and then you start asking yourself, oh, well, I don't get paid to do this. But then you start to realize like, but none of this matters if I'm not doing this. So being a health disparities researcher who focuses on healthcare access and utilization, I would say that a lot of my work is interesting and novel, but understanding and identifying the disparities that are occurring at the most vulnerable intersections of identity isn't always the most encouraging. So while I think that the previous work that I've done has been really valuable and important, I'm really excited about the direction that I'm taking my work in now. I'm thinking a lot about how to make healthcare more affirming. That's really been what my work has been about. LGBTQ affirming care, culturally informed care, culturally sensitive care, care that's going to be appropriate, respectful, and safe for patients no matter what their race and ethnicity, sexual orientation, gender identity, age, ability, status is. And when I think about some of the resilience that you would see, or the ways that people in the LGBTQ plus community have been approaching healthcare, a lot of the time you'll have experiences where folks will avoid care or limit interactions as much as possible, and that works up until a certain point. As we get older, the ability to avoid care becomes harder and harder and harder. As older adults, we interact with the healthcare system constantly. And then at some point, even with the most informed and heartfelt chosen family or family and friends supporting you, you may have to have a care provider come into your home. And to me, and from just anecdotal experiences, that's one of the most vulnerable experiences that people can have. You hear stories of older transgender people hiding putting up pictures from their past life, or hiding pictures of their spouse, or you being forced to use their dead name, and how oppressive and stifling that can be, especially when you should just be aging with grace, and really being able to reap the benefits of all of the work that older LGBTQ adults have done to really help us achieve a lot of the freedoms and the rights that we have today. And so thinking about creating interventions and trainings to really improve the understanding and the cultural competency of providers that are going to go into people's homes is something that I'm really excited to start delving into, researching, and also co-creating tools and interventions with older LGBTQ adults so that we can co-produce better opportunities for better care. It's lived experience. Like I honestly, I have a really good friend, AJ Adkins Jackson. She's at Columbia. She's a brilliant socioepidemiologist, and she says that if the data doesn't match up with our lived experience, the data's wrong. And so it's like when we're trying to unearth and uncover why things are happening, like the big why, right? And like not in like the what causal inference equation can we do, but like really like why are these things happening? How can we start to disentangle these persistent and consistent inequalities and health outcomes? It's just like the easiest thing for me to do is to go back to lived experience. And so like very briefly with like the local hospital segregation, that came out of like reading the literature, and like there are articles that were saying, oh, it's residential segregation and it's patient choice. Maybe Black patients just like going to worse hospitals because there are more Black doctors there. And I was just like, no, we don't. Like I've been a Black patient. I recognize that like there's this one hospital. It was called hospital. You could like my best friend's uncle literally died in the emergency room. He got shot. They made him wait. He bled out. Like just ridiculous. So when my dad got sick at the beginning of the pandemic and had an aortic dissection, he had like emergency surgery, and it was just like super scary. And then like a few months later, he's like, oh, I have to go back for like a small procedure. And I was like, okay, Dad, well, where are you going? Because as your loved one, I care. And he was just like, oh, hospital. I must have like we don't even have phones to drop, but I was must have dropped the phone. The dial tone went off. I was about to run to the airport. Like, Daddy, don't go to. And he was just like, oh, no, 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 no. This they closed that one down. This one's in Santa Monica now. It's much better. I did my Googling. I was like, okay, this is a much better hospital for my dad. So when I'm reading these articles and they say that Black people just choose to go to lower high mortality hospitals because of, choice, their own choice, I'm just like, no, we don't do that, because we all know where the bad hospitals are. We all know when people are being treated poorly. And then on top of that, even when Black people live in next to better hospitals, they're still going to worse hospitals. And I know what it's like to have been a Black person who lives in a predominantly white area, walk into a hospital and everybody's looking at me like I'm crazy. I was in New Hampshire suffering from had some crazy back pain for months. And I got there, I called my chair. She was like, well, they're not going to do much because they're going to think you're seeking opioids. So just take this and call me in the morning. I'm just like, what? All the PhDs in the world aren't going to stop me from walking into an emergency department and someone thinking I'm drug seeking because I have lower back pain. That's wild to me. And it's like, I'm smack dab in the middle of this white area. I'm smack dab next to the best hospitals. But it's like, I'd probably go somewhere else where I've talked to a few people who can tell me, like, all right, you could actually get help because I know you're in pain. So it's just like, it was just lived experience. And now it's just kind of like use the evidence we have to demonstrate it. Like, I would say 9 out of 10 of the papers I write, I feel like, duh, but listen, I know it, but the general literature doesn't quite know it yet. We haven't put a p-value behind it, so no one cares just yet. And so it's just like, oftentimes I find myself just pulling from my own lived experience, pulling from the lived experiences of my friends, people I care about, pulling from the experiences that I for people that I talk with, and try to see if we can create some evidence, because once you have evidence, you can do something. And so that's kind of where I am in my career, trying to build enough evidence so people will believe us when we say, hey, you're harming us. I hope that my research has impact in two ways. I like to think of it as policy with a capital P and policy with a lowercase p. When I think about policy with the capital P, I would love to see national policy around paid family leave, including chosen family, around allowing chosen family to have legal rights and protections when there are caregivers to individuals who are aging without kin. And that extends across a lot of different groups. People might think of it as only older LGBTQ adults who didn't have children, but there are people who outlive their children. There are people who outlive their siblings and their spouses. There are people who are estranged from their family from a variety of reasons that can all really benefit from policy that allows folks to choose who they want their family to be, and the law to recognize that. So if my work can do anything, I really want to impact that capital P policy. Now, the lowercase p policy that I think about is in health systems and hospitals, in the day-to-day, in practices. I would love to create interventions that are implemented widely in hospitals and health systems, at residential housing facilities, so that folks can really understand that it's not enough to just be LGBTQ friendly. It's like we really need to be more inclusive, to be more away, and to be LGBTQ plus inclusive and inviting and accepting and celebrating. It's like tolerance is death. X-Men, Marvel 97. You gotta watch it, it's a good one. But tolerance is death. It's about acceptance, it's about celebration. And if my work can do anything to help us move in those directions, I can go to my maker knowing I did my best. It's time. When I was doing it, it was called food deserts, and then it evolved into food swamps, and then now it's food apartheid. Yeah. It was really just a pulling back to the actual time that I was doing the work. Yeah, it's a thing. I realize that we talk about language a lot, and it's a constant, it's a push and a pull, it's a struggle. And I want to, when thinking about liberation, one of the most powerful things that people can do is name themselves and to name their affliction. And so it's one of the things that I want to make sure that I stay abreast on, but I think as academics we need to be better about, is rather than creating language, listening to the people and using the language they have for themselves or for their experiences. Because I think oftentimes, I think food deserts became a specific designation, and then as the movement started having a social justice movement, the language of food apartheid came out, and I was like, okay, so it's the people taking control of this movement. It's the people being a part of their own liberation. It's the people leading their liberation. I'm just here to leverage whatever privilege I can, whatever expertise and resources I can, because we're all, it's like going back to my upbringing, we're all a part of the body, and no part of the body is more important than the other. but if we work together, we can do some amazing things. When the body tries to do different things, it's when we have problems. You can't go left and right. You got to move together. So I think about, so I took a training. It was for women of color in academic medicine by Kemi Dahl. It's called Get That Grant. And I really loved that training because one of the first things that we did was make a purpose mantra. You know, it's just like why are you here? So a lot of people, we talk about it in different ways. Sometimes this organization has a mission statement, or so for this is like your individual mission statement, right? And so my mission statement was to create evidence and demonstrate the role of policy in creating inequitable access to healthcare, and to equip people to be active participants in their own liberation. You know, and it's just kind of like, so everything that I do, I try to think about that. Like, am I creating knowledge or impacting policy or equipping people? Like, those are kind of ways that I try to think about that. And so it can, like, academia is its own interesting, you know, behemoth, monster, body, whatever you want to call it. It's its own thing. And one of the things I realize is that as long as I'm following my North Star, it doesn't matter what vehicle I'm in. And so if I'm ever in a position where I can't do those three things, I just get into a different vehicle. And so if I find, my hope is that my life is long. I plan to live to be 104. I really want to see how this AI thing works out. But for the most part, if my life is long, I will find myself in various places, and I think that this season of my life, I'm building the tools, I'm building the evidence, I'm building the resources, I'm building the street cred, and then I might be burning things down or not. You can't hold me to it, right? But it's just like, I just find that, like, for this season, this works, and I recognize that life happens in seasons. The first time I met someone who got a PhD the year I was born, I was like, oh, you can do more than one thing. And so this is what I'm doing for this season, and who knows what I'll be doing next.